Good morning, everyone. Welcome to the Elkhart Rotary Club. It is a fantastic start to the week here on a Monday. And if you start your week on Sundays like some of the wall calendars, we can no longer be friends. This is the beginning of the week. So welcome, everyone. It is great to be here. So happy to see you all. I would love to have Ann McQuistion come up and give us some thoughtful words.
I'm really thoughtful today. Thank you, Eric. So if you guys will join me, gracious God, we ask for your guidance, wisdom, and support as we begin this meeting. Help us to work within Rotary to do your bidding. Help us engage in meaningful discussions, push us to grow closer as a group, and get to know each other better. Please encourage our club to nurture our community, our country, and our world. Join me in the pledge. Pledge allegiance to the flag of the United States of America and to the republic which stands, one nation under God, indivisible, with liberty and justice for all. And the four-way test.
All right. For those of you at home, you might understand the dangers of moving the four-way test from one side of the room to the other on the wall behind us. But you know, product placement's pretty important, so we'll have our Coke and Pepsi signs up here behind us shortly. But until then, it'll have to be the Rotary banner. All right, Aaron Wagler, would you like to come up and introduce our guests?
All right, I'm really bad at reading handwriting, so please excuse me if I botch your name, but we have, we have a visiting Rotarian from Syracuse, Doug Grant. And Melinda has a guest. And then Sharon will be introducing our guest speaker later. So, thanks.
Welcome to our guests. Sorry, we're doing an experiment with the microphone and the camera, and we have to switch it up. Okay, really quickly, just looking online, just wanted to welcome all of you here. And again, if you wouldn't mind renaming yourself, it's a good Zoom skill to have. So I'm not sure we have iPhone on our roster for the Elkhart Rotary Club. So if that is you and a club member, would you please change your name there? That would be great. Okay, and also Tom Schaff and David Damerow, thank you for helping and jumping in for check-in as Erin was a little delayed in her arrival, so thank you for that. Okay, if anyone has announcements, go ahead and come on up. And while we're doing that, I just wanted to make a plug for the morning division. They are meeting on Thursday morning, and they're actually doing a hands-on service project for the Big Brothers Big Sisters of Elkhart County on Thursday morning. So these are those sorts of things that if you are a group or a not-for-profit that needs some hands-on work, please don't hesitate to reach out to Bob Gerard. They love doing that, and that's also an opportunity for any of us. If you want to get up, bring your own coffee. It's a nice way to get up on a Thursday morning, go and make some stuff and have some fellowship with a fun group. Our Noon Division meeting on October 11th, we'll welcome Milana Maher, the president and founder of Aging Connections. She's going to talk about collaboration versus competition. And also our Noon Division meeting on October 18th will feature Margaret Goldsmith, and she's the coordinator of Camp Mariposa. So we'll learn about what great things they do there. Just a review of service projects, and Tom is going to talk about County Road 6, but I wanted to mention that Boot Lake service dates upcoming this Saturday, October 9th. If you want to meet at Boot Lake at 10 a.m., you don't even have to get up early. That's a great thing, the morning division, not having to be there at 7 o'clock, and they're going to do some work up there. You can check that out, and I will leave it up to others with their announcements.
Hello, everyone. Let's see if I go up on my releve. All right. Hi, I'm Julie here with representing the Guatemalan Project. Thank you to those of you who came out and helped make the 4 dresses that were completed and the 2 underway. The goal is 10, and there are kits available for anyone that wants to maybe take a kit home. I know some of you gentlemen are probably experts with your sewing skills, so we've got some kits for you. We'll line them up at the front. You can come and see me. Also, we're still accepting supplies, school supplies for the kids in Guatemala. And of course, your generous donations are very welcome. We'll be accepting those through the end of October. Thank you, everyone.
So I'm Sharon Herstein. You're going to get a double dose of audiology today. October is Audiology Awareness Month, and I just wanted to take this moment to remind you all, this room is looped. If you are having difficulty hearing and you go into the T-coil position, you will hear much better. And if you need supplies to get looped and to use the services here, get in touch with me because we do have supplies in the closet. Thank you.
Okay, this room is looped. I'm sure there's a joke in there somewhere. However, I'm going to bypass that. Saturday, October 23rd is our County Road 6 cleanup day. So I'm going to send around a sign-up sheet for you all. We have 2 choices. The normal choice, which I call the eastern area between County Road 13 and 17, and then the western area that meets over there at Cleveland Little League. So we're going to be picking up trash in both areas. I'm going to send around a sign-up sheet. Be willing to sign up today if you would. Thank you.
Awesome. And thanks, Tom, for having that. So, Tom, is that Cleveland Little League area, is that ours as well, or is that one that we just haven't?
The morning division.
That's the morning divisions. Okay, good. So yeah, we've got a choice. So the bigger question is, which one's cleaner? Which one will we be out of there quickly on? Okay, excellent. Let's see. I don't believe we have any not-for-profits here today to talk about grant funding. But you could be not for profit right now. Is that how things are going? Nice to see you, Tony. Okay. So we're just flying through this part of the meeting. This is great. Dave Neeser, are you here today? Dave's in trouble because Dave was scheduled to be sergeant, but I am not in trouble because you might remember it was back in August, we had a little fun activity. And we did not get through all of the awesome information about some of our club members. So we're going to continue that today, and we're going to learn a little more about our club members. Was there anyone that wasn't here on that day when we learned more about all of our individual club members? You missed it, if so. So here we're going to do, we'll start at my table with Sharon. So Sharon, and Chelsea, you're welcome to guess just random names, but we're going to put all of our hopes on Sharon for this one. So this Rotarian lived for a year in a rural setting without running water or electricity. During the rainy season, I would brush my teeth with water from mud puddles because it was less muddy than the stream. So what Rotarian was that?
Mel Jacobson.
It was not Mel Jacobson. All right, that is, I didn't even say the rules or really what we were doing. We're raising money for our fees today. So Sharon, no fine for you because of the interruption, and a fine for everybody else. Sherm, you ruined it for everybody. Everybody pays $1 for that. So any other guesses who the Rotarian might be who lived for a year in a rural setting without running water or electricity and brushed their teeth in a muddy puddle because it was cleaner than the stream? Is it Ashley Bowen? No. Yeah, 2 years. Would the Rotarian who lived in that condition identify yourself? It is Doug Risser.
Dave Easter is here.
So where was it, Doug? And welcome, Dave Neeser. You have your materials ready? Oh, you're set. I only had to vamp for like 2 minutes. Doug, where were you? Where you had to?
Down in a rural community in Bolivia, right where this is located now,
Very nice. On a service trip. Did you say Bolivia? Bolivia. Yeah. It's for those at home. Doug, if you need to bone up on your Bolivian trivia, talk to Doug Risser. Now we're going to welcome the real sergeant up here today to help us raise some funds. The one, the only, Dave Neeser. Rousing applause for Dave.
Good afternoon, happy Monday. Today's Monday. Man, it's October. How's everybody doing? We good? I got one thumbs up. Okay. Don't be too disappointed. We won't be doing the say something nice about Stan Cohen Day today. If you want to, you can. That'll be after. You know, the goal up here is to raise money, get the fines. You know, everybody might as well get your $5 out and be ready. But I'm dispensing advice today, primarily relationship advice. I'm an expert. Ask my ex-wife. Anyhow, show of hands, who is in a relationship? Oh, even Stan. Good job, Stan. All righty, so you're gonna pay $1 for each of these. First of all, if you have a date with somebody, and I did this intentionally, don't be late. Everybody put in $1. I had a girlfriend once back in the 80s. I was just gonna say that. Anyway, point number 1, relationship advice and observations. This will cost you $1, just so you know. Love is like death. You won't know what it's like until it happens to you. Okay, that wasn't that great. We're gonna go on to number 2. It's still gonna cost you $1 though. So everybody put in $1. Okay, this one applies to me. Best relationship advice. Everybody have your dollar ready, okay? Make sure you are the crazy one before you commit. Did I hear somebody say I got that one? Okay, that's reasonable. I'll take that. That's $1. Okay, my favorite one of the ones I have. Get your buck ready. When your ex says, when your ex, you'll never find anyone like me, you respond, that's the point. That's the point. Okay. So just move on then. Just, it's better to move on. That was a buck, by the way, just in case I didn't tell you. One of the last points today on relationship advice, second to last, don't bring baggage from an ex relationship into your next relationship because it will be a short trip. I kind of like that one. Okay, last one is a relationship joke. You guys love these, I can tell. Okay, get your last dollar out. Okay, relationship joke. Two satellite dishes meet on a roof. They fall in love. Get married. Wonderful ceremony. It was okay. Ceremony is okay, but the reception was brilliant. I'm going to eat lunch now. Thank you.
I love it. That was short and sweet, Dave. I'm thinking I should have kept going with the materials here. I think we're gonna do a bonus one, right?
I got one.
We're gonna do a bonus. Hold on, no. These are our, let's see. Oh, here we go. One more interesting fact about our fellow Rotarians that I did not get to in August. This Rotarian coached a member of the 2021 Milwaukee Bucks NBA championship team. I was Jeffrey Teague's basketball coach when he was in the 3rd through the 6th grade. Any guesses? Don Stoller. It is not Don Stoller. That's a good guess, though. It is not Kurt Janowski. I may have made a grave error and not actually had the right Rotarian in the room at the time of reading this. Is the real Rotarian here? All right, we'll save that one for another.
Online.
Oh, he's online. He's online. I'm sorry, I didn't even see you there. So that was Paul Gardner, everyone. Paul Gardner coached the 2021 Milwaukee Bucks NBA championship team member Jeffrey Teague. That's pretty awesome. Paul, thanks for submitting that. That's very cool. And sorry I missed you on the online. That's perfect. Okay. All right. For our program today, I would like to introduce Dr. Chelsea Twyman. Chelsea is an audiologist with Beacon Medical Group, and she's going to talk to us a little bit today about cochlear implants. As Sharon had mentioned, it is Audiology Awareness Month. I think I butchered the title of that earlier in this in the last month. But we're going to learn a little bit more about that. And I know she's going to tell you a little more about herself. But one of the things that she mentions as a goal is to help her patients have a better understanding of how an audiologist can help restore relationship between them and their loved ones. And I think some of these are important. I thumbed through your presentation a little bit. I'm sorry I previewed, I cheated. But it's interesting, some of the things that I, not being one who has these problems, at least myself now, am starting to understand a little bit more with those that I interact with, many of in this room on a daily basis, who may have some of those challenges, and also some family members. So Chelsea, the floor is yours. Come on up and we'll get this shared up here, everyone. This. And then you can just hit any button. I'm gonna duplicate this. There you go. Excellent.
Thank you.
And I'm gonna double check and make sure that we got you.
Yeah, I guess I should have wore the heels.
No, you're good. There you go.
Casual.
Perfect. Thank you for being here.
Yes, thank you. Can everybody hear me okay? Good volume, awesome. I'm glad that you guys are a funny group because it's been a while. COVID has knocked out a couple presentations I typically do. But yes, the main discussion today is about cochlear implants, a little bit about how they differ than hearing aids because not everybody is a cochlear implant candidate. And quite honestly, we don't want you to be a cochlear implant candidate unless you truly need it. So the goal is to learn a little bit more about that. And you likely know somebody as a friend or family member who would be a candidate and they just don't know it exists out there yet. So a little about me. I was born and raised in Ohio, small town. We have a potato festival and a potato queen. That's what we're known for. But I went to Kent State University for my undergrad. I entered actually as a dance major and then switched over to the medical area a little bit later in. Awesome. And then after that, I continued for my graduate degree. So I have a doctorate in audiology, technically from a program called NOAC, which is a consortium between Kent State University, University of Akron, and the Cleveland Clinic. So while the University of Akron and Kent State run our academics, Cleveland Clinic determines our clinicals. For your fourth year in an AUD program, you have to interview to get what we call an externship year, where you work, well, you should, under full supervision of another audiologist before you can graduate. And I did this down in North Carolina at Wake Forest Baptist Medical Center. It is a full service audiology department, and that is where I actually got to learn a lot about cochlear implants for pediatrics and adults. Career-wise, so far I'm one and done. I came up here to work with Beacon Medical Group. It's been a wonderful experience, and I'm still with them. And then a little project I have related to Beacon is one of my passions is pediatrics. So I have a program called HICOM. It stands for Hearing Impaired Children of Michiana. So the point of this program is to get kids to see other kids who have hearing loss, whether it's hearing aids, cochlear implants, whatever it may be, because it's really hard to be a kid in school who has hearing aids and not know anybody else that needs them or has them your age. So I really pull from all of the Elkhart County schools together so kids can meet one another. And sometimes we have kids drive up from like 2 hours, like somebody drove from Fort Wayne another day. Just depends on what the event is and if the family member can make it. So highlights, we're going to talk a little bit about hearing loss just to give you a background, a little bit about what a cochlear implant is, kind of show you what it looks like, and then the steps on how does somebody qualify and what does the patient actually have to go through if they want to pursue a cochlear implant. So in our world, there are actually 3 types of hearing loss. So it's the audiologist's job to find out, 1, do you have hearing loss? 2, what type is it? And 3, determine by the type what is going to be the most beneficial treatment for you. So just briefly, a conductive hearing loss is usually due to a physical impairment of some kind. So like a hole in your eardrum, ear infection, and they can be more severe physical issues, but it's something physically that's stopping the sound from getting to the sensory portion of your hearing mechanism. Sensory neural hearing loss is in red up there because a sensory neural hearing loss is the one that we use to treat with hearing aids or a cochlear implant, whichever is more appropriate. And this is a loss that's either sensory in nature or neural, which is why we combine the term sensory neural. And then a mixed hearing loss is just how it sounds. If you have a mixed hearing loss, you have a little bit of a sensory neural component, but also some of that conductive component as well. So if you think of a patient who went through a larger ear surgery at one point in time, maybe they had to clean out an infection behind the bone, something like that, they probably have a physical component. And then as they get older, they will also have some of that sensory neural hearing loss as well. So what is a cochlear implant? So a cochlear implant involves two parts, and whenever anyone hears the word implant, they always get super excited when they see me because they're like, it's an implant. No one's gonna see it. You're gonna see it. There's an outside part and there's an inside part. So this is the inside of the cochlear implant. This right here, there's a circle up at the top, and that is actually the magnet underneath the skin. The big square and the circle kind of on top of the square, that stays very lateral, meaning it's very much just under the skin, and the surgeon would drill a little pocket for it to sit so your head isn't bumping out when they place it. And then what looks like the tail is actually inserted deeper through the skull to get inserted into the sensory portion of your hearing mechanism called your cochlea. Again, so on this picture, the one in the middle is an internal component, but the two on the outer sides there, those are both external options. So while the middle would be inside under the skin, the two on the outside would be worn on the ear, or we call it on the head. So the image of the black cochlear implant is the standard processor. Every manufacturer who works with cochlear implants makes this type of processor. And if you're familiar with hearing aids, it looks a little bit like a specific type of a hearing aid with an extra cord on it. Now the gray one is what we say an on-head only processor, meaning that there is nothing hanging or touching your ear. It's just a circle that's placed in the same area that the coil for the black processor would be in. There is only one implant company that makes that type of processor at this time, and not everybody is an ideal candidate for that processor, but it is available because patients want something that is less noticeable or less heavy on the ear at this time. Any questions about anything so far? Feel free to interrupt if you have one. If I click on this, do we think it'll play? Maybe. Sure. All right, we're going to try to open up this link. It's just a quick video on how a cochlear implant works. And I thought they did a good job keeping it simple, but doing a good explanation. It does have a closed caption. So this is that standard processor that every company makes being worn on the ear with the cable attached to the head. And you can see the gray part that's supposed to be under the skin. That's where the internal magnet is. And then the black portion on the outside where the circle is where the external magnet is. And that's how they communicate, is one magnet attaches to the other, and then it's a coil transmission. So that's what they're explaining now. And then you'll see that it sends a signal down to the cochlea itself. So that circle that kind of looks like a snail shell, that is your cochlea, and that is where the tail on the implant, we call it an electrode array, but you can think of it as a tail. That is what your surgeon has to technically drill a hole into and thread around for you to get good sound stimulation from your implant. So it's very important that you go to somebody who does cochlear implants on a regular basis, not somebody who does them like once every 3 months. And you can ask your surgeon how many they do. They're used to that question. So how, yes, go ahead.
So how do you know if somebody is a candidate for?
For a cochlear implant? Oh, that's in there. It's coming.
And just make sure that they ask us repeat question.
Oh, she wanted to know, how do you know if somebody's a candidate? And we are going to get in that a little bit later in the presentation, but it is coming. So how do a hearing aid and a cochlear implant differ? Well, a hearing aid is using all of the hearing mechanisms you already have built in your body. It's just amplifying sound in a different way. A cochlear implant is actually taking the signal and is changing it into an electrical stimulation of some kind, which gives your brain the chance to learn how to hear again in a different way. And because of that, that's why you actually have to have hearing loss in both ears to be able to get a cochlear implant. Because if you have a perfectly normal hearing on the other side, the side that we implant, it won't learn to retrain to that new sound stimulus because you already have a stronger ear that is still recognizing sound normally. Okay, so who qualifies for a cochlear implant and what do we look for? So there's multiple steps to being a cochlear implant candidate. So the first one is, do you have the correct type of hearing loss? Do you have the correct degree of hearing loss to pursue a cochlear implant? Are you a surgical candidate? A lot of my patients who are older, they just think that they can't do it. That's not for them. The great news is it's a longer procedure because it's a delicate procedure, but it's not a rough procedure on the body per se. You usually go home that same day. You're allowed to get up, walk around. If you want to go back to work, you can, but they recommend taking at least 5 days off just because you're supposed to keep your head dressing dry for that time and clean. But as long as you don't have a cardiac issue that your heart couldn't take the anesthesia during the procedure, you're usually cleared to have the surgery if it's what you want. Is this person in a stable life situation? So this is where it gets a little hard. So cochlear implants, when you think of children learning language, and we always talk about how the first 3 years are the biggest language window opportunity for kids. When you get a cochlear implant, that's essentially what you're going through, but the window is much smaller. So we have to be sure that you're going to be able to get back to the clinic and get the programming done over and over, because we have to see you quite often in the first 3 to 6 months before we can start spacing you out. In this area with our adults and our kids, reliable transportation is one of our hardest issues to overcome. We also need to make sure, does your insurance cover the procedure? Also, we work with the Amish community. Can you have rechargeable devices? So a lot of times with the standard processor, we can use like a standard battery in it, but the batteries don't last very long in that manner. So yeah, so we use rechargeable implant pieces for the most part. So that's also another thing to consider. What is your lifestyle like? Does this go with your belief system as well? Do you fully understand what's going to happen? So this can be hard to judge. Sometimes we get patients in the door and it's like their spouse or their adult children who are really pushing for this cochlear implant, and it's a little hard to gauge. Does the patient actually understand what is going to happen if they get this implant? So typically when you get a cochlear implant, the reason you have to have a lot of hearing loss is because you will lose some, if not all, the hearing in the ear that we do implant, meaning that if you're not wearing your implant, you won't be hearing from that ear anymore. And then learning to hear all over again. So again, the day that we turn the implant language. Is this person motivated? So I just saw a patient on Friday, and this is a great case. He's very well educated, nice man. His daughters really wanted him to come have this evaluation. And I said, okay. So this is my second time meeting him. I had like a standard hearing test with him a few weeks ago. Brought him back in, and you can just tell he's not in a good mood the entire time. Doesn't want to answer any questions. And for that patient, the question is, are you actually going to do the work to be successful with the implant?
the surgeon is gonna place the implant and then he or she is out of the picture. I'm the one working with you from that moment out, and it's my judgment call. And I just told this patient very pointedly, I said, my fear is you are somebody who gets frustrated, you're impatient, and this is not going to work in 3 months. You usually have to have your implant on and do rehab, like listening rehab for at least a year before you can get a really good benefit out of your implant. And if you don't, when I go back to that idea of the language window, if you don't take advantage of the time you have when you first get your cochlear implant, you can't make it up. Like that first year is very, very important. So even though he was a hearing candidate, he was a great surgical candidate, I suggested we not do the implant, and in my note, I said he is not a good cochlear implant candidate based on expectations, motivation level, and life circumstances, because he had some other things as well, but mainly his motivation was what worried me the most. Now, he can go somewhere else and be evaluated, and if they feel that is different, then they can go ahead and do that. I also offered, now may not be the time. You can do the testing, you can repeat the testing. It's not a one-time and you can never go back. So that's okay too. And my recommendation was come back in 1 or 2 years and do it again. I think you'll feel a little different about it. So the last thing is, does this person have a support system? For you to learn to hear with a cochlear implant, you have to be hearing speech. So if you're somebody who's older and you don't have any family around, you're not very social with friends, you kind of stay to yourself in your own home, it's just you and the TV, that person's gonna have to do a little bit of extra work to be able to hear live speech with their implant, to learn to decode speech while wearing it. So that's that kind of goes back to motivation as well, because I have lots of patients who live on their own and their adult kids have uprooted and moved, and they will find ways to communicate with others. I have some that come to the clinic and I will read to them. If they're willing to put in the effort, I'm willing to put in the effort, but that is a question of, are you actually going to get access to speech with your current lifestyle? Yes.
You're mentioning in-person speech, so now that so much of our world is interactive and hybrid with like Zoom, would they be able to hear their television, Zoom, off their telephone? How does that work?
Yep. So the question was, we all went a little virtual here and we're still doing lots of hybrid things. So with that in mind, can implant patients stream, I'm gonna call that stream signals from like TVs, or even just hear it from the TV, from the computer monitor, things like that? And the answer is yes, but it's not going to come through as crisp and clean as in person. If that's what we have to work with, that is what we will do. But usually what we'll end up doing is, I'm trying to give a great example. So I worked at a VA once for one of my extern positions, and it was remote care, so it was a lot of telehealth. So in that situation, that is what you're doing, and you have to try to control your environment as most as possible. So make sure you're giving a really clear, clean signal. Make sure the patient is in a nice, quiet area. And then there are accessories. So like this room is looped for telecoil. There are also accessories to help stream even like presentations from a computer to the implants. So a lot of hearing aids these days will stream Bluetooth signals, and so will the implants. So there is a way to do it, but you want to control the environment as best as possible. Nothing is going to be live speech though. Yes.
If a person has very marginal hearing and decides to undergo a cochlear implant, and that implant is not successful, is there a risk that that person will have less hearing than when he started?
Yes.
And what is the percent of implants that are not successful?
So the question was, if somebody has a great amount of hearing loss and they decide to pursue an implant, is there a risk that the implant won't work and they can be in a worse position than they are in? The answer is yes. I actually have a woman coming in to see me this week. She was like the best candidate you could imagine on all sides, and she's just not performing well with her implant. Just like hearing aids, there are a lot of programming parameters, we call that mapping parameters, that you can change in a cochlear implant. So we're not done with what we can and can't do. but she is not where I'd like her to be for how long she's had the implant. And we do counsel patients. There is no way to know that you're going to be a rock star performer or that you're not going to be able to pick up on this and learn to decode it. And again, that is why you have to have a strong, well, a large amount of hearing loss in both ears. That's why the criteria is so strict in general. And then the other part of that question was the failure rate,
Yes.
essentially. So it depends how you define failure. So failure by a cochlear implant manufacturer, like the statistics you'll see for their companies and such, is going to be smaller probably than what you're thinking of when you say failure. So failure means that the device actually like didn't work and it had to be explanted, and we either did not put another one in or we went in and put another internal component. The rate of that happening is essentially under 1%. When it comes to failure into how well the patient does with it, there isn't really data on how, like a percentage on how many patients really fail, because other people also have very different expectations for themselves going into it. Personally, the majority of my patients do very well. I'm very strict with my patients about their rehab process. But again, I can't reiterate enough. There are places, criteria is criteria for a reason. You shouldn't go outside of it for that exact reason. You don't want to risk your patient losing more than they could have gained. But there's not a great answer to that question, so I'm sorry. Okay, qualifying for a cochlear implant. So with adults, the criteria is a little bit more lenient than children. It is all through the FDA who makes these mandates. And this is in regard to the amount of hearing loss. And the reason that also is because we can do more testing and have a more thorough exam with adults, so we can see a bigger picture compared to our pediatric patients. Mainly, if you're an adult and you wear hearing aids and you still feel like you can't understand what is being said, so you can hear that everybody is talking, but you can't understand it, that's usually the flag to potentially get an updated hearing test or a cochlear implant evaluation and see how you do with your hearing aids on in multiple speech and word testing parameters. For pediatrics, it depends on how old you are exactly, but under 2 years old, if you have a severe to profound hearing loss and you're not meeting your language milestones, that would be enough for implantation. If you're older than 2 years old, there is some additional testing. And again, even then it's a little tricky to do, because if you have that much hearing loss, you're already so far delayed in your speech and language milestones that we usually have to rule out other diagnoses as well. And that's when we bring in psychology, developmental, pediatrics, things like that, to do a full case conference for those kiddos. This is what I see typically in my clinic when it comes to a patient pursuing a cochlear implant. So usually a family member or friend, spouse expresses concerns about their loved one's hearing, whether they have hearing aids or not, they're expressing the concern. The patient either gets hearing aids or the patient already has hearing aids. But over time, they're still not understanding speech better, they're just hearing it better. And then at this point, usually the primary care will refer to ENT if the patient goes back and says, I got these hearing aids and I still can't hear with them, and they keep adjusting it. Most primary care physicians will then refer to an ear, nose, and throat physician to rule out any other medical issues that could be interfering with the speech understanding. I did make a note in here. I don't know if we have any docs in the room, but it does delay a patient's journey when you refer to the ENT versus an implant audiologist, because the ENT almost needs that testing to figure out, what am I going to do for my treatment option? Is a cochlear implant going to be beneficial? Is there something else I should be looking at? So you can actually take off about 3 to 4 weeks of your journey if you actually get referred directly to the audiology department or an audiologist in like a private practice setting, something like The patient then gets referred to the cochlear implant audiologist. It's a long exam. It takes about an hour and a half to 2 hours, depending on what information we have prior to you arriving. If you are deemed a cochlear implant candidate, so again, if you're testing in regards to hearing, if your motivation, your support system, if everything looks like you would be a good candidate for a cochlear implant, that's when you get referred to a cochlear implant surgeon. And then they will go through your medical history and make sure that you're going to be an okay surgical candidate for the procedure. Who do you refer your patients to? I get this question a lot, and it really depends. So if there is a patient who I know has a very abnormal physical feature, a syndrome, something like that, we do tend to refer to otology. We do have some more local providers who can do the procedure but that is more of an ENT physician, so they handle more of these standard cases that we don't have any imaging concerns for.
What was that last?
Mhm.
Yeah. Oh,
Your nose and throat,
and-
and then the first one, yeah, otologist. Yeah,
So can you help me understand? I'm having a little difficulty when you say that someone can hear but can't understand. So am I picturing like, and I'm not trying to be funny, but like Charlie Brown in class with his teacher, where it's where you're hearing something but you don't know what the words are? Is that what you're saying? And if that's the case, what's causing that breakdown? Can you explain that a little bit?
so the question is, we're having a hard time understanding the concept of hearing, but not necessarily understanding, and is that like Charlie Brown and his teacher and hearing wah, wah, wah? Yes, I think almost a better analysis for these patients in particular is, and this has happened so much back in the day, but if you ever had a stereo and you were trying to like crank up the volume, and once you got to a certain point, you almost heard like the actual stereo going in the music or the ball game, whatever you were listening to, sounded more like staticky and it just wasn't as clear. Has anybody ever done that back in the day? That's kind of a better situation, I think, to describe it, because for these patients, it doesn't matter how much volume we give them, the hearing nerve still doesn't decode the speech appropriately. It's still not a clean signal. The issue is, and you can't exactly pinpoint exactly, but you know that it is somewhere in the cochlea, likely due to damage of the inner hair cells, or the hearing nerve itself due to the fibers, or myelination. Any other questions? So if you meet your CI surgeon, they'll do a case history intake. They'll do some kind of imaging. It's usually a CT scan. If it's a younger kid, we'll usually do an MRI just to be sure for anatomy purposes. You do have to have specific vaccinations to get this cochlear implant because it does put you at risk for something called meningitis. So it is 2 vaccines that you have to get. And then they'll tentatively schedule a CI surgery if the cochlear implant evaluation has already been done. So sometimes we get the primary care and they did a great job at referring to the cochlear implant surgeon, but they didn't refer to the audiologist for the evaluation. So it just kind of depends how the patient gets to the end point. But at that point, if you've had everything else in order, they'll usually give you a surgery date and say, as long as everything else is completed in the next 3 weeks, you'll be good to go. So just timeline example again, some patients come in my office and sometimes they think they're going to get the cochlear implant 3 weeks from then, and it usually doesn't work out like that. We have a lot of winter birds here, which is great. They like to go to Florida, but they'll come in October trying to get everything done by November and not realize like the rehab portion either. So for those patients, if they are a candidate, I say this is a great opportunity, but let's wait till you come back in March or April. So usually the primary care, if they refer to audiology, it'll be a new patient. So right now with resources and staffing, it's usually about 3 to 4 weeks. You'll get referred to the CI surgeon, which you're usually a new patient for that physician as well. So that's another 3 weeks. You have to start the paperwork for authorization with your insurance. It can be as quick as 2 weeks. It can be as long as 8 weeks. It really depends on your insurance type. We call that the payer. So that's why it says approval can take 2 to 8 weeks. So just as a side note, altogether, it can take anywhere from 13 to 16 weeks from the day the referral was placed to audiology till the day you get the surgery. Essentially, most patients are getting their cochlear implant 8 to 12 weeks after they've had their implant evaluation with myself. If everything is lined up, like if you're already an established patient, or like sometimes Sharon will send me records and we'll have some more information to go off of, and we can kind of streamline your appointments more quickly that way. So it is possible to have it done in 4 to 6 weeks, but it typically doesn't happen that quick. A question I get, and this is fun, are they MRI compatible? And I'm smiling because when I did my externship back in 2016, they weren't. So if a patient got a cochlear implant and they needed imaging done, they would have to come up to our department, and the CI surgeon would actually have to numb it, put a small slit right here, pop the magnet out, head wrap, go down to imaging, come back up, sterilize, get the magnet put back in. And it wasn't necessarily a painful thing, but it had to be very coordinated. And it definitely was not a fun thing for the patient. So at this point, you don't have to take the magnet out. It's just that it can only go up to a certain Tesla strength. So a Tesla strength is how we measure how strong the imaging for the MRI is. Sorry, I thought I heard it clicking. And that is dependent on the manufacturer and the implant that is placed. One thing to note is if you are getting a cochlear implant, if you have a medical condition that they need to do MRI imaging and they're specifically looking at the head and neck area, that is something to consider, because even though you're safe to get the imaging done, it doesn't mean that the image is going to come out clear to continue to monitor that issue. So for example, I have a 16-year-old patient who would be a great candidate, but he has brain cancer and we need to monitor that. So he cannot have his cochlear implant at this time. Things I recommend to patients if you do get a cochlear implant: keep your ID card in your wallet. So a lot of manufacturers will give you an ID card on your company. It'll have the name, sometimes even the device and the serial number. So just keep that in your wallet. Put your manufacturer phone number in your phone. That way, if you're out and about, if you have a medical emergency and you need to get a hold of somebody, you can just say, the number is in my phone, and anybody can actually call that phone number. So any physician, x-ray technician, whatever, and they can even ask for some of the details once they prove that they're a medical staff member who is treating you. And then possibly wear a medical bracelet. A lot of my patients don't do this, but again, if you're somebody, like if you have a history of seizures or epilepsy, something like that, I will say, make sure you get a bracelet that says, like, I have a cochlear implant, because if something were to happen where your implant got knocked off of your head, if it's not on your head, it would be somewhat harder for somebody to know that you have something underneath the skin by the time your hair grows back over the surgery site. So what does the cochlear implant evaluation entail? So we measure, depending, this is our second or first time meeting you, your current hearing thresholds. We take hearing aids and we do program them in a test box. To me, I call this your prescription setting, to make sure you are wearing appropriate amplification. A lot of times if I am seeing a patient who's referred from an outside hearing aid provider, sometimes the issue is that the hearing aids just aren't programmed well, or they were a completely inappropriate fit in the first place. So this patient is right, they aren't hearing well with their hearing aids, but it's actually because the hearing aids themselves and the care they've received is not appropriate. And if that's the case, they'll usually do very, very well on their candidacy exam, and we'll talk about getting a different set of hearing aids or returning to the provider, transferring if possible, so they don't have to buy new devices, but it really depends on what the patient comes in with. The patient's asked to repeat back sentences in quiet. They're also asked to repeat back sentences with a speaker behind them with quite a bit of static going. They're asked to repeat back one word at a time. And in that test, I really like that test because it's not just, did you get the word right? It looks at how many parts of the word did you get correct. And then this is just some of the case histories of cochlear implants that I've done recently with some surgeons. Before I go into this, did anybody have any other questions so far? So in this scenario, there's an 80-year-old man and there's an 80-year-old woman. The male wore hearing aids for at least 10 years before he got his cochlear implant. So the diagram on your left, we call that his audiogram. That was his hearing of his right ear. So just for reference, anything from -10 to 25 is normal. Anything after 90 is a profound hearing loss. So he really isn't hearing anything if he doesn't have a hearing device in on the right side. When we did his testing, to qualify for a cochlear implant, we do multiple testing because we want to be very thorough and have a full picture, but the FDA actually only mandates that you do one specific test. His score for the right ear in quiet was 18%, meaning that when he's wearing his hearing aid on the right side, programmed to the best abilities that it can, like the strongest hearing aid on the market, he's only getting 18% of what somebody says in quiet. If you throw in noise with the speaker, he got absolutely nothing. So that was in June of 2020. So I saw him recently in May, so May 27th of 2021, almost his 1 year mark. And where you see the C's coming in at 25 and then his one threshold at 30, that is his detection thresholds with his implant. So he has sound awareness at each of those frequencies, essentially within the normal hearing range. On the bottom, when you look at his implant scores, so this is actually 10 months post-activation because you have to wait 1 month after the surgery to be activated. So 10 months, he's had his implant and his scores on the right side went from 18% to 78% in quiet. His scores in noise went from 0% to 79%, which is excellent. It's phenomenal. And this patient, when I talk about unrealistic expectations, this patient actually told me at this appointment, I don't know if I would do it all over again. And I said, really? He goes, yeah, I mean, I'm hearing, but you know, I want to hear better. And we're talking, we went from 18% to 78% in 10 months. And I know he's done the work because I work with him. And that's what I mean about realistic expectations and really gauging these patients. And he had transferred to me during his activation. So he's very interesting, but lots of progress. I have an 80-year-old woman and he moved very, very well. So when we activate an implant, we try to find a spot that's comfortable, but all patients will hear, there's no way around it, a very high pitch squealing or buzzing sound. And unfortunately, you have to hear that for about 3 days. Every day you put it on for at least the first 20 minutes. It's very much like if you were sleeping and somebody wakes you up by just turning on the lights and it's nice and bright. So I always tell patients, wake up, have your coffee, put your implant on, just relax for 20 minutes and then start your day. So it's nice and quiet, it'll simmer down, and then you can go about your day. But when I say we have to do a lot of mapping in the beginning and programming and making sure that patients come to those appointments, it's because essentially every week we're sending more electrical current through that implant to get you better detection thresholds, because he wouldn't have started on day one with detection at 25 in the normal hearing range. His detection on day one probably would have been in the 40s or 50s. And our goal is to get you to that point. Because he had worn hearing aids for so long, his hearing nerve had some kind of stimulation, even though it wasn't the best it could have. So he adapted pretty well. Now my other patient, she's an 80-year-old woman. She's never worn hearing aids. And I did her cochlear implant testing, and I did not think there wasn't a reason to really make her do a hearing aid trial if she strongly felt that she wanted a cochlear implant. I was that confident that that was her best treatment option. She has a fantastic support system. So I did her test in January of this past year. So her right ear in quiet with the hearing aid got 30%, left got 19%, and with both hearing aids together, she got 34%. When it says the CNC left, so that's the word test I was discussing earlier. So she actually got 32% of the words correct, but she got 42% of the phonemes. So a phoneme is a speech sound within a word. She met with a surgeon. She had her surgery, and I saw her recently in September. So her detection levels now are within the 25 to 35 range, but it was really hard because she would not let me bring her out of the moderate hearing loss range, even with her implant. And I had to have a discussion of, I'm going to put you in the booth and we're going to find out if I'm being really mean or if you're being a little wimpy, because this is important. You have to make this jump now. I cannot stress that we cannot catch up. Beginning is very, very important. So her daughter was there, put her in the booth. Turns out she's being a little wimpy. So we talked about it and she said, okay, I'll do it. I said, okay. So we came to an agreement and this is what she came in with. I was very, very happy to see that. And we talk about like progress. So this is 3 months post. So the one guy was 10 months post. This lady is 3 months post activation. Her left ear is now getting 36% compared to 19%. It's really too early to test her in noise. She hasn't had it long enough to be able to decode that well yet. But her word scores also improved 42% overall and 61% of the words correct. So what that means is like the man's voice on the tape may have said, say the word hat, and she repeated back cat. So she got the act, she just didn't get the beginning of it. And then for this one, this is a case, like a pediatric case. And he's at a very rough age to implant. A lot of audiologists don't want to implant kids once they hit like 3 years old, maybe 5 years old. In his case, he actually was born with normal hearing. He had progressive hearing loss. He got linked with me about 4 years ago, and he's been in hearing aids since. And for pediatrics, we make sure to test their hearing once a year. And I noticed that his word scores on one side, they drastically dropped. And I said, okay, let's come back in 4 weeks and recheck it. Came back and it was still terrible on the left side. So his hearing loss, just in regard to like tones and pitches and detection, is over here on the left. So his right ear did very well in quiet with the hearing aid. He got 65% of the words correct. His left ear got 5%. With both together, he did great. He got 74%. But when you look at those scores, his left ear is not giving him speech understanding. It is giving him detection, but not speech understanding. When we put him in noise, so this is a kid, this is a 10-year-old boy. His classroom is not quiet. His gymnasium is not quiet. His home life is not quiet. He has 3 siblings. There's always commotion going on. So we test him in noise and his right ear gets 9%, which is his stronger ear. His left ear got nothing, and together equal 32%. So based on his quiet scores, he wouldn't qualify, but when you look at his noise scores, he does meet the criteria. His left ear also only got 12% for the words, 32 for the parts of the words. He was interesting because I don't think nobody wanted to do it, but it had to be done. So we had talked and we said, we think this is best. We kind of warmed him up to the idea. He's a very bright boy. He has an implant and he kept telling me, he's like, I have a headache. I don't think I can wear it. And I said, I'm like, yeah, you can. Let's check it out. Come on back. And I brought him in, and sure enough, we were so like proactive, and on top of it, he actually had fantastic stimulation just even in that first month with his implant. So I actually had to back off the current a little bit. He's doing really well. But after 2 months of having his implant, his left ear got 60% compared to 5%. And noise, his left ear got 54% compared to 0%. And then his word scores also improved greatly. And the reason I show this is it is a lot easier for a kid to progress with a cochlear implant than an adult because the brain is still a little bit more plastic and pliable in our childhood to learn to reroute and rewire. He's also very stimulated auditory because he's in school. So he's getting classroom instruction for at least 6 hours a day, along with socializing at lunch and recess and things like that. So there's just challenges that adults have to overcome that pediatrics do not. Lastly, untreated hearing loss. I think this is important. I don't think we recognize sometimes hearing loss can be the root of some of these issues. So for psychological issues, anxiety, depression, fatigue, we call it listening fatigue, but also social withdrawal or isolation. So a lot of times when patients come to see me, my question is, do you like to be a homebody, or are you a homebody because you can't communicate with others and you get frustrated? Physical, it's been linked to poor cardiovascular health, diabetes, type 2. For memory, so there's not a study out there that is saying hearing loss causes cognitive issues, but there are multiple studies now saying that when we look at these patients who have these cognitive issues and we look at the degrees of hearing loss they have, we're seeing a link of some kind. I just want to make that clear. I'm not saying hearing loss causes memory issues, but what I'm saying is when you review all of these cases, it is much more prevalent in patients who have hearing loss. They also have memory issues that are worse than their normal hearing peers, or patients who do have a hearing loss and wear appropriate hearing aids or a cochlear implant. And it can also lead to, a lot of people find this interesting, but it can lead to lower pay rates. If you can't hear well, you can't communicate well to express thoughts, concerns, and you often get overlooked for promotions because of that. So this last stat is, although 27 million Americans age 50 and older have hearing loss, only 1 in 7 uses a hearing aid. I know it's not directly related to a cochlear implant, but just in the grand scheme of hearing loss, that's how much people seek treatment or follow through with treatment once it's provided or recommended.
Chelsea will be around and answer questions if anyone would like to do that. We're getting a little tight on time here. I wanted to thank you, Chelsea, for coming and presenting today. We'll have some passes for Wellfield Botanic Gardens for you. That is a project that this club actually founded back in 2005. And to everyone, just a quick reminder that there are other clubs in this area that you can go to lunch at. One of those is Wednesdays. Anybody go to the Concord Club for lunch? It's Wednesdays. They meet down at Bent Oak. This Wednesday at Bent Oak at the Concord Rotary Club, they are having Paul Cataldo talk about the National Pizza Championships. So if you want to go to a good lunch and have probably, I'm guessing will be entertaining. I'm afraid I can't make it, but I'm going to try to go to that one a little bit more. Go check that out. And also, one of my favorite authors, Simon Sinek, he's an author, inspirational speaker. He said, hearing is listening to what is said, while listening is hearing what isn't said, or just hearing all kinds of things. Have a great day. Rotary's adjourned.